It might take a minute because I'm connecting from Kinshasa here.
Perfect.
I hope that you can follow.
That looks great. Thank you very much. And the floor is yours, Pia.
Thank you so much. Hi, everyone. I'm Pia Huq from the Social Science Analytics Cell in the DRC. I will be presenting to you about the use of social science integrated evidence in public health responses, using examples from the Ebola and COVID responses in the DRC. And I'm actually here in Kinshasa, so I might turn off the video just to ensure that the connection stays strong. So a quick introduction about CAS at first, the Social Science Analytics Cell. We're an operational research unit. We've been active in the DRC since 2018, the 10th Ebola response in the east of the country. And we were created with the Congolese Ministry of Public Health, as well as humanitarian partners. And we very much see ourselves as a service to the Ministry of Health, as well as partners in public health. So our objective is to conduct rapid and near real-time analysis to inform responses to public health emergencies. And we do that by using an integrated approach, integrated outbreak analytics approach to be specific. And that involves integrating data and analysis from different sources and types to provide a more complete picture of a given health situation. So to give you a bit of a more concrete illustration of how that works, we use data of different actors, and also different types of data. So we look at epidemiological data and the epi situation overall. We look at data from the use of health services, as well as individual perceptions and behaviors, and healthcare workers' perception and availability of care. And we also look at the factors that might influence this data. And so that would be the context, for example, data on gender norm, conflicts, etc. We look at trends in prices in markets, because that can have a huge influence on health-seeking behaviors, of course, as well as events such as policies, public health measures, and the timeline. And this is how we try to get a more complete picture by having this multidisciplinary integrated data to understand not only vaccination, but all different types of diseases, public health crises, and situations. So as I said, I'm going to talk to you about the use of integrated social science evidence in the Ebola response and the COVID response, trying to draw from our experience to explain what could be the challenges and ways to ensure that the data is actually being used. It's one of our main objective at CAS is to always make sure that the data is actually being used, because otherwise we know that there's already a lot of data available, so there's not, like, why collect more? And we would rather make sure that the things that we have is actually already being used. So the Ebola response, a few elements of context. First of all, in the Ebola response between 2018 and 2020, all the actors present had one very strong common goal, and that was to stop the transmission chain and to stop the outbreak. And the area was specific and delimited. That was North Kivu and Ituri. And you had response teams deployed on the ground everywhere. You had a relatively strong coordination with daily meetings with all the partners that were sharing the information. So in this context, CAS research, our integrated data, also focused on the different pillars of the response, such as IPC, WASH, surveillance, communication. And the recommendations that we co-developed from this data was also specific and localized. And we also developed an engagement approach where we made sure to involve all the local health actors, including the Ministry of Health, from the beginning, just to make sure that the data was used. So this made it easier for the integrated data to actually be used by the different actors, as well as the fact that they could clearly see the link between the data, the recommendations, and the common goal of outbreak control. So to give you a more concrete example of what I mean, here looking at communication, what we found is that initially, the messages and the posters about the Ebola symptoms focused a lot on the very severe signs of Ebola, such as bleeding. You can see here at the bottom of this poster. And these are the signs that only occur in the final stages of Ebola. And so our research showed that by only showing these very severe signs, it had an impact on health-seeking behaviors from the communities, because what we want is from people to go and seek health and healthcare when they're in the initial stages of the disease. And if you're only showing them the last stages, they're not going to be able to recognize when to go and seek care. And it also had an impact on the trust, because people could not reconcile what they were seeing around them in the community with what they were being shown in messaging and posters. And it also had, lastly, an impact on the ability for healthcare workers to detect suspected cases when they received it in their structures. Because if you're looking for someone bleeding from their eyes and their nose, you're not going to think about fever and muscle pain, joint pain, which are actually the initial very common signs of Ebola. So based on this data, communication teams were able to change their posters and messaging and actually talk about the initial less severe signs of Ebola, which you can see here: headaches, fever, joint pains, muscle pains. Another example that we wanted to talk about is that our studies showed that communities identified water as their priority need. In our approach, our CAS approach, we always try to keep a focus on community, the realities of community and their needs in terms of health. And so in our studies, we were able to show that they identified that water was actually what they needed first. And so a lot of water supply systems were built in Ebola-affected areas, which is great. But here again, we see that actually water can be strongly linked to stopping the transmission of the disease, because water can be used for IPC measures in health centers, but also bringing water to communities was a way for the response team to rebuild the trust. And so here again, you can see very clearly that you could see the link between our data, the recommendation, and how to stop the transmission of the disease, which we said was the one common goal of all actors. And all of that made the use of integrated evidence much easier, because everyone could see the purpose of using this data. When it comes to the COVID response, and this is the second part, the second example that we want to talk about, the context was obviously very different. Because the CAS was identified as a best practice of Ebola, we were also part of the COVID response when it started in the country, and we brought along our similar approach of engagement with health authorities. But as I said, it was very different because, first of all, it concerned the whole country instead of only a limited area. And what we saw is the data coming out of our integrated approach showed that actually the larger impacts of the COVID response were much more serious for communities than the impact of the disease itself. What the data showed, not only our data, but integrated data and data from a lot of different actors that from the beginning put some light on the fact that the larger impacts of COVID are very serious in communities. We showed that the household incomes were severely impacted by the COVID measures, such as lockdown and travel. We also saw a consequence on access to healthcare, and we also showed that the impacts were even more severe for women and girls. But as you can imagine, it was much more difficult to link these impacts with stopping the transmission chain. Mostly because it was outside of the response's mandate. It requires, long-term investment, and it is difficult to prove that by taking an action about these larger impacts, you can actually stop the transmission of COVID. So then we decided to focus on data that we could make sure is used. And this is where we decided to focus on community health needs and overall public health situation. So even now the COVID is still a reality, but we are trying to do research as well on plague, on malnutrition, on measles outbreak in the country. Because we know that this data will be more easily used. So a quick example, again, to illustrate what I was talking about. Here we have this study made by Ilan about the disruption to incomes and the percentages of households that were in debt because of the COVID measures. Sorry, this article is in French, but it also shows that actually the malaria situation worsened during COVID. Here, this study from PERC shows that 51% of low-income households were having difficulties getting medicine, and 39% were delaying or skipping healthcare visits because of the economic crisis. And we also showed in our data and national information data that the sexual and gender-based violence increased during the lockdown period in the urban areas of Kinshasa and Goma. So what we see, again, is that larger impacts of the global and local COVID response are more harmful to communities than the disease, and that it is difficult to link these impacts to stopping the transmission of the disease, which can explain somehow that it's more difficult to use them. Here again, more information about the health context and the structural issues in the DRC. Here you're looking at the number of measles vaccine per health facility in a health zone of Kinshasa, and you can see this dramatic drop from the end of 2019. And again, more articles about how malaria remains the leading cause of death in DRC Congo, even during COVID. So here, it's again to highlight the importance on focusing on other health needs based on communities' priorities. Because for communities, if they're dying of malaria, how are we going to talk to them about COVID? And sometimes communities' priorities are not our priorities. So here, coming to an end already. So we see that the use of data was very different in the Ebola response and the COVID response, and we had to adapt to make sure that that integrated data was being used. And so in the Ebola response, it was made easier by the context, as I said, by the approach that we developed based on engagement and appropriation, and also because the data was linked to stopping the transmission chain. In the COVID response, we met some challenges in getting this integrated data on broader impacts use because it affected the whole country. It was much more difficult to have an intervention, specific intervention. It required interventions outside of the COVID response setting, and it was difficult to link with risk control. So what we are doing now to get this data use is that we are focusing on community health and using our integrated approach to, on the one hand, of course, keep advocating for a better, more respectful and holistic response that takes into account the broader needs of communities and their priorities. But we're also pushing for action on other non-COVID related health issues. All right, if you have any questions. I think we made it in time.
You did an amazing job. Thank you so much. That was great timing. And if I might just add to this excellent presentation that you made is by just saying that the UNDP has projected that the level of development we'll be seeing over the next, due to what happened in 2020, will take us back to levels of poverty not seen since the 1980s globally, and that the impact on health inequalities is basically just going to be unprecedented. So your approach and what you have just described in your approach being much broader now is just absolutely essential. So thank you so much for that presentation. And we have a few minutes for questions. If anyone has any in the conference center. I don't know who can point to anyone because
I can't see either.
We just see a blank podium. So if anyone can help us, that would be good. Are there any questions there?
Maybe I'll take this opportunity.
I have one question. Okay. Sorry, the microphone was not working.
Okay, all right, well, go ahead with your question.
Yeah, sorry. So first, thank you so much. And I have a very difficult question for you, but how can a biologist help with you? I mean, how can we maybe have, you know, to find some risk population that are more at risk, and then to conduct policy that are maybe targeted to some population which are at risk? How can a biologist can help you in your work? Tough question.
Thanks for the question. I think one of the great things about this integrated approach is that we welcome more disciplines to come within us, and actually how by looking at data coming from your field, we can also, by putting it with all the different type of data, how we can get a broader picture. So we, for example, worked here in Kinshasa with the Antwerp Medicine School of Tropical Medicine, because they did a prevalence study for COVID among healthcare workers. And so by using that, we can also look at perceptions and behaviors of healthcare workers and see how they perceive the risk, and then compare it with the reality of whether or not they were exposed to COVID. And it's just, yeah, the idea of bringing all the data together so we can have a better understanding. And what you can bring to the table with biology, it gives us another lens and another way of looking at the situation. I hope this answers the question. Merci.
Excellent. Pia, did you want to add anything as well? You were about to say something. Do you want to?
It was just to what you said about looking at health inequalities. And I think it was guided for us by obviously what you said and the absolute need to look at it, but also always thinking, can this data be used? And what partners do we have that can actually take action based on that? And that is also one of the reasons why we try to look at the broader picture.
Great, thank you. I'm about to give the floor to our next speaker, but just before I do so, I want to say thank you to Pia. And thank you very much for connecting from Kinshasa. And just to say something about the biology, one thing that I think biologists can help with is just knowing that human biology is socially patterned as well. So that when we're sampling, when we're doing these measures, to be aware that our biomarkers are responding to our environment and we embody our environments biologically. And this can lead to health outcomes that are different. And I think this is a key point that often just kind of slips us by sometimes. But thank you very much. We're going to move on to try and stay on our schedule, which is listening to all these really interesting discussions and presentations. Our next